safety of protocol of surgical team, OPD, IPD, and operation theater in this COVID era. I would like to thanks to all the member, chief guest, special guests, and the speakers both from Bangladesh and India, also the faculties, panel of experts, and everybody. Thanks to very much to participate in this program. You know, our today's chief guest is Professor Habib Millat. He is the chairman, Health Advisory Group, Inter-Parliamentary Union, and our special guest today, Professor MD Nazmul Islam Munna. He is the line director, Medical Education and Health Manpower Development, Director General of Medical Education, and General Secretary of Society of Otolaryngology, Head and Neck Surgeons of Bangladesh. Our speakers is Professor ABM Jamal, a Professor of Surgery, Dhaka Medical College Hospital, and our another speaker is Professor Dr. Partho Sarathi. He is minimal access surgeon, head of Department of Esophageal Surgery, JAM Hospital and Research Center, Coimbatore, India. So, our panel of experts is Professor Shafkat Hossain Khondokar. Professor Shafkat Hossain Khondokar. He is the ex-president of Society of Surgeons of Bangladesh. And our next panel of experts is Professor Mohammad Sanarullah Sheli. He is the president of Society of Surgeons of Bangladesh, Chittagong branch, and professor and head of the department, Southern Medical College, Chittagong. Professor Dewan Ali Hassan Choudhury, president, SOSB Sylhet, and professor and head of the department of surgery, Sylhet Usmani Medical College. And Professor Rafiqus Salehin, professor and head of the department of surgery, Mugda Medical College and Hospital, Dhaka, general and laparoscopic surgeon. This seminar is presided by the Professor A.H.M. Tohidul Alam. He is the president of Society of Surgeons of Bangladesh. Society of Surgeons of Bangladesh is concerned about the current situation of the coronavirus disease, COVID-2019, and cautiously monitoring the pandemic, ensuring the overall safety for our fellow colleagues as well as for the patient seeking surgical care is of our major concern. So the Society of Surgeons of Bangladesh from the very beginning provided guidelines, distribute some personal protective equipment, mask, and ensure that everybody time to time how to proceed in this COVID pandemic situation. I would like to many thanks to our chief guest. Even in his busy schedule, he gave our time. I give thanks Professor Konokkanti Borua sir. He is our senior, and he's the vice chancellor, and he's our guide on all aspects of the Society of Surgeons of Bangladesh. Now I would like to request Professor ABM Jamal to deliver his speech about the safety protocol of surgical team in COVID pandemic. His topics is safety protocol of surgical team for OPD and IPD. OPD, dealing with the OPD and IPD patient. Dr. ABM Jamal. I request Dr. ABM Jamal.
Now, am I audible?
Yes.
Okay, yes. Fine. So I just want to share my screen. So I want to put my request to Raj TV to share my screen in front of the audience. So learned audience, my dear surgical faculties and members of the Society of Surgeons of Bangladesh and all the participants in this webinars. I'm happy to see the Honorable Vice Chancellor of Bangabandhu Sheikh Mujib Medical University. He is actually our guardian of the surgical community. And in this August gathering, I also want to mention that yesterday we got a good news for surgeons community of Bangladesh, that one of our renowned surgeon, Professor ABM Khurshid Alam sir, he just appointed as the Director General of Health Service yesterday, and hope that he will join in the next morning in his new portfolio. So it's a good news for all of us, despite many of the bad newses and many of the shortcomings in this COVID era. So I want to just share with all of you a glimpse of the safety protocol, which might need some modification in this COVID period. Usually, we practice in general surgical conditions. So, so I think now the slides are visible to all of you. Is it okay?
You go to the share screen,
Yes.
please.
Okay, okay.
Yes, we can see. Yes.
Okay, you can see. Okay, fine.
Yes, visible.
So, if we considered the safety protocol in the outpatient department and inpatient department, mainly surgeons are more acquainted with that of the operation theater. But before entering the operation theater, every surgeon has to maintain some standard protocol in the OPD and IPD, because this is the normal gateway of most of the surgical patients. And this is the normal areas where we can devote our
interruption. We couldn't see your slides. Only the computer desktop is there. Slides not seen.
Okay. Okay, now is it? Is it?
Now we
okay,
can.
okay, fine. Thank you. So actually in OPD and IPD, these are the some in somehow in our mindset, surgeons' mindsets, it's a little bit neglected area regarding the safety protocol, following the safety protocol, because most of the surgeons are mostly concerned with the safety protocol usually in the operation theater and after that. That means in the postoperative recovery rooms and the postoperative areas. And we often provide or emphasize on the follow-up schedule as well. But sometimes we see that very simple protocol, following very simple protocol may help to recover most of our surgical patients, and we can mitigate our mortality and morbidity in many of the cases. So starts with the very basic thing declared by the WHO, that clean care is safer care. And this clean care is safer care is not only applicable in the medical sector, but also in surgical arena as well. Because we know that in every aspect of the surgical procedure, we should follow the cleanliness, and we should not, in terms of the cleanliness, this is not a general cleanliness. It is the actually the care of the surgical patients as a whole. And if we consider what has modified during this COVID-19 pandemic outbreak, there are very little data till today available regarding the surgical outcomes in relation to COVID nowadays, because that surgeons are mostly deals with non-surgical patients nowadays. And you see, if this data initially published by the Italian scientists, they have shown that significant decrease in acute care surgical workload, about 96.9%. And they just discovered that every surgeon's main mindset shifted to that of the surgical procedure, to that of the medical management of the patients who presenting one of the surgical problem, but their main area of interest shifted to that of the medical management of those patients. And another thing they have scientifically, they have mentioned that the redistribution of duties, this is a very important thing, that the COVID involvement in our country also, many surgeons are involved in management of the COVID patients. And they are mainly involved, especially the junior surgeons, the trainee surgeons. And they are mainly involved, not the surgical procedure, but they are involved in the COVID management of the non-surgical as well. So this is very important. And in Italian scenario, if we follow the Italian scenario, we can see that about 43.3% of the surgeons assisting the non-surgical patient. That means about half of the surgeons are engaged in non-surgical procedure in Italy, and most likely in other parts of the world also. So if you see that some of the common operative procedure, if we consider that one of the common operative procedure in our emergency surgical area is appendicitis, and our routine surgical procedure is no doubt but cholecystectomy. So they have seen that increase of the conservative treatment in case of even some intra-abdominal infections and some acute emergency condition like diverticulitis, 50 to 60% of the patients shifted to that of the conservative rather than surgical procedure. So these are the things actually which is put the surgical team members to involve in non-surgical procedure and to involve in ward management mainly. So this is one of the important findings. But if we consider the surgical site infection, why we are so concerned the surgical site infection in this COVID period also? Because in normal situation, post-operative infection rate in US is about 2 to 3%, where the highest number of protocol is followed usually, and the highest number of their safety measures as it is being followed in the USA mostly. And among surgical problems, surgical site infection are the most common hospital-acquired infection, accounting for 38% of all such infections. So many a times we see that surgical site infection is the big problem for any hospital authority, and it covers about 38% of all the untoward or acquired infections in any hospital. So we have to rethink about this in our COVID era also. And most common nosocomial infection is hospital-acquired infection. And this is the area where we have to emphasize our attention, because you know that corona, though it is a viral infection, not considered as an important nosocomial infection, but it also affects the surgical procedure as well. And when surgical patient with hospital-acquired surgical site infection died, 77% of the death were reported to be related to that infection. In our recent experience in Dhaka Medical College Hospital, we found that the surgical procedure, the mortality and morbidity, and even not only the mortality and morbidity, the surgical site infection in emergency situations, because we are mostly dealing with the emergency surgical procedure in Medical College Hospital at this COVID moment, we found that most of the patients, surgical site infection, the incidence a little bit higher than that of the normal scenario. So we have to rethink about this, that at the COVID scenario, the surgical infection actually overnumbered than that of our expectant number of wound infection. So what's the problem in front of us? WHO has summarized that there are 7 main problems of infection-related problems to consider the safety measures we have to take in. The 1 in 10 patients get an infection while receiving care at the time of receiving either in the OPD or in the IPD. And up to 32% of the surgical patients get the post-op infection, and 51% are developed antibiotic resistant. So these are very important. And we also see that even the patients who are suffering for corona, so they are also receiving the antibiotic, sometimes not justified by the scientific basis or the evidence base. And 90% of the healthcare workers do not clean their hands in some facilities. So we have seen that this scenario has been changed in COVID period, because most of the healthcare workers are concerned about their own safety. So this is not due to the safety practice for their patients. This is actually the scenario has changed due to safety of their own infection possibilities. So infection cause up to 56% of the death among hospital-born babies also. And up to 20% of the African women get a wound infection after a cesarean section. So this is also an alarming. And 50 to 70% of the injection given in some developing countries are unsafe. So till today, that the contamination from unsafe injection is also prevalent in some of the underdeveloped or less well-equipped countries. And one of the big problem, WHO has emphasized that antibiotic resistance is a big problem for all of us, and we have to take care of these antibiotic resistance as well. But if we consider the problem of COVID-19 globally, then we think that the COVID-19 is one of the infection which actually affects all 4 sorts of zonal involvement. That means individual, institutional, national, and global. And we see the institutional and individual problem is mainly affects the healthcare workers. But the national and global scenarios are mainly involves the decision makers, the law enforcing, and also the people who are involved in the decision-making process, like WHO, like national governments, like even the different regional organizations. So they are mainly involved in the global scenario, and they find it's a highest, and that's why they convert it in a pandemic situation, and they call it as a pandemic. So if we think that, if we consider the microbe nature, then we don't forget the basic microbe nature still prevail in case of this COVID-19 scenario. That means contamination, and most of the suggestions or most of the advice put forward to prevent the COVID is mainly targeted to that of to prevent the contamination. And to prevent contamination is the main way. And we know that any microbes, which mainly the contamination is the main area where we can easily and we can cost effectively control this stage of contamination. Next, we see that when this convert to that area of the colonization, then actually it starts as difficulty to all of us. And at this stage, actually, sometimes it's called alarming. And we are mostly concerned that when an organism start to colonize, then actually though it is mainly applicable in terms of microbiological, that is bacteriological, but we think also that the colonization is many fold, and most of the patients of the COVID affected by or involved the respiratory infection are main problem is the colonization. And infection, we see that many of the infection in this time is actually secondary or the drug-resistant infection, and this infection is also an important problem for all of us. And if we start from a green field to that of the contamination, colonization, and up to the infections, so anybody can think about after infection, actually, do we have any solution? If we consider that an infection has happened to a particular person and there is involvement of the organ, and at that stage, do we have actually real solution? So we should consider this and we should think about this. And if you also discuss about the risk factors of surgical site infection, we also should consider our problem of soil, our problem of seed, and our problem of fertilizer. And we have to take care that all these things, sometimes all these things come forward in combination. And in that case, the problem of infection is very difficult to control. And we see in this COVID situation that the emergent secondary infection or drug-resistant organism is the main factor for most cause of death in this COVID era. And if we go back to our basic surgical attire, then these are the most important thing. And one of the interesting thing is that this surgical attire mostly practiced by the surgeons for many years and many decades. But nowadays we see that almost every healthcare providers, they are practicing this type of surgical attire. And in this field of training surgical attire, I think in every institute, surgeons are the main mentors or main trainers to all the medical staffs to train how to use properly or scientifically the surgical attire. And one of the things we usually emphasize or re-emphasize many a time that wearing this surgical attire is very important, but the dropping or the removal of this surgical attire is more important than wearing of this kind of surgical attire. So in surgical context, this is an easy thing for the surgeon's view, but not for all other healthcare workers who are not acquainted with these kinds of surgical attire. One of the important protocol we usually follow to combat morbidity and mortality in surgical area is that practicing surgical safety checklist. And WHO recommended surgical safety checklist actually gives a good protection for all the patients. And you see that about 1/3 of the mortality and 1/3 of the morbidity as become we control 1/3, or we can cut off the 1/3 of the mortality and morbidity if we practice surgical safety checklist universally and for every patient. That's very important. So we have to follow this surgical safety checklist as a protocol to prevent the surgical problems or surgical outcome. And it's not a individualized thing. It should be followed in every case and during every operation. So this is one of the important protocol we have to follow. Another interesting thing, we see the change of the death pattern after the appearance of the COVID. If we consider from China to the global scenario, in China, most of the deaths and most of the cases detected in mainland China, that is one, actually they diagnosed after death or they diagnosed at the stage of severe cases, and very few number of cases they diagnosed in a symptomatic way. And they never thought that some of the patient may remain in their community as an asymptomatic case. But if you see nowadays, in globally, we see that in other countries, more symptomatic cases and more asymptomatic cases than that of the death rate or in other countries nowadays. So this scenario has changed, that due to practicing the universal protocol or due to knowledge developing after this nature of virus spread, the number of deaths in comparison to the number of the affected case is gradually lessen in number in all parts of the world. So this is a good and this is a hopeful thing for all of us. And this is the only hope nowadays, that the number of deaths should be as minimum as possible. And almost in every day, our forecast in Bangladesh, we see that never our death rate rises about 1.3 or 1.4%. So constantly, we are in between 1 to 2% death rate. But in some countries of the Europes and other North American or South American countries, we saw that in some countries their death rate rises as high as 8 to 10%. So in this context, our subcontinent is lucky.
Jamal sir.
Yes.
Sir, 3 minutes, please, sir.
Okay. I will complete by 3 minutes, no doubt. Okay. So if we consider this problem, so what are the ways of our solution? So one of the important solution is that of active infection prevention. That is very important, and use clean practice, what we are advising almost every day, and hand hygiene, enough staff. This is very important. Infection monitoring, and never reuse of our needles and series, and reduce the risk of resistance. So these are the important solutions. Now, I want to show you that if we follow the patient safety, what will be our advantage of following this patient safety? We saw that during last century, improving public health is credited with adding 25 years to the average life expectancy of populations in resource-rich countries. So this is the advantage of following a safe practice or a protocol-based treatment module in everywhere. And if you see, this is a Swiss cheese roll slides. We see that incident doesn't has happened by a failure of a single protection. It usually happens when there is failure of multiple protection at the same time and in same way. That's the most important thing. And if we want to control these hazards, any kinds of surgical hazards, we have to follow this Swiss cheese model, and this is very important. And in that case, we can cut down our complications. In this context, we can follow the aviation safety procedure or the nuclear explosion center, nuclear center procedure. They follow the main principle that are the root cause, they attack on the root cause, they combat the human factors, hazard identification, and control some measures. So these are the important aviation safety procedures we can follow. Now, lastly, I want to advise all of you to follow a model as a protocol for safety of the patients and healthcare workers, is that shell model. Shell model is nothing, but it's actually models of the technological services. They follow the thing that if we control the software, hardware, environment, live wire, and central live wire nicely, In that case, we can control the morbidity in our hospital settings. But if we just remodel this shell model in our healthcare workers, most of the time, we usually emphasize on the live wire. That means doctors, nurses, and other healthcare workers. But many times, we forget about providing or emphasize on software and environments. So this is very important that we have to put our attention to that of the software and environment. So in that case, the live wire will be in a healthy association and they will follow. So what is our dream? Our dream is that in an operation theater, it's not a part of my discussion, but if we follow the OPD and IPD, then the operation theater, most of the things of the operation theater can be controlled by nice digitalized way, and many times it can be controlled outside the operation room, so that the patients and the healthcare workers who are involved in the surgical procedure, they become safe by themselves. So with these few words, I want to conclude my delivery. So thank you all. Thank you for this.
Thank you, Professor ABM Jamal, for a nice discussion. I give thanks, and we are honored that Professor Konakanti, most of the senior professor of our country, Professor Konakanti Borua, Professor Motiur Rahman sir, Professor Mujibur Rahman, Professor Tuhin sir, Professor Firuz Kader, Professor Mojammel, Professor Shaddare Naim, Professor Ishel Bishas, and Professor Mozammel, and also so many people with us. Now I would like to request Dr. Partho Sarathy. His topic is safety protocol of surgical team for operation theater in the COVID era. So I would like to request Dr. Partho Sarathy. Please continue your speech.
Good morning to, good evening to all. Once again, I like to thank Society of Surgeons of Bangladesh to giving me this opportunity. Sunday, I had a discussion with you, and again within 5 days, other topic. So I'm very happy to this delivering this lecture. And during this COVID time, and nowadays even in my part of cities, a lot of patients we are getting in my cities almost every day we are getting 200 cases, and we have started seeing in OPD also. Last week cases are increasing. So almost 3 months we started taking a lot of safety measures from each level, from OPD, ward, and ICU. And I'm going to show you what are the safety measures in OT, that is operation theater. So I like to share my screen. Are you getting my slide? Are you able to see?
Yes.
Okay.
Yes. Yeah, you can see.
So this is a safety laparoscopy during COVID pandemic.
Yes.
Yeah. So managing COVID in a surgical system, first thing is we have to educate all staffs, including healthcare workers, sweepers, everybody's to the PPE, personal protective equipments. It's very, very important. I'll tell you in detail. And usually we nowadays we are postponing the elective surgeries. The reason is we want to save the personnel in the OT and then the personal protective equipment. And fortunately nowadays we are getting all coverall, mask. So all the PPEs are available. The early phase in the March and April, a lot of demand for PPEs. So we postponed the elective surgeries. Nowadays we have started doing elective surgeries also. So, and another aim is to decrease the healthcare staff exposure. That is also very important. And then we have to develop a care plan providing for essential surgeries. And we are coming to the OT, and we need a dedicated COVID operation theater. Suppose if we have 5 operation theaters, we have to 1 or 2 should be allocated separately for only for COVID patients, and a regular case will not be operated in that. And in suppose if it is a dedicated OT, there should not be any unnecessary item inside the OT. So we have to clear off all the things. So the OT should be for boils, theaters, OT, and tables, and main all the important equipment, unnecessary item to be storage item to be taken out. And there should be a minimized traffic in and out. Suppose if you want to shift the COVID patient from the trolley from outside area, otherwise called preoperative to OT, there should not be any interruption. The pathway should be clear. No one should there the pathway, then we can shift. The same way out, taking out also we have to clear the traffic. And recovery in operating room until isolation room is ready. Suppose if you want to shift the patient for isolation, should not keep it in a regular ward, and then ask the patient isolation is ready or not, take out the lift, everything separate, so that you can immediately shifting the patient to the isolation room, so that no one during the transport time will be affected. And then some person to keep the transport pathway clear. So these are all the small point, and this is one of the important article. So all the emphasis, all the smaller point, that is very valid one. And I took some of the information from SAGES, that is Society of American Gastrointestinal Endoscopic Surgeon, and then European Association of Endoscopic Surgeon. What is the recommendation of during COVID-19? So most of the association, even in India, AMASI, Association of Minimal Access Surgeons of India, and IAGS and CELSI, they all together form a guidelines. And most of the guidelines repeating, they're telling the same point again and again. So I highlighted some of the different point of SAGES and the EAES. So here in the OPD, they advise for minimize the face-to-face consultation. We have to go for a virtual meeting. So like what we are like a Zoom meeting, we can talk to the patient. You will be in OT, you will be in a hospital, but consultation will be virtual. And coming to the laparoscopy, there is a little evidence of risk, minimally invasive risk specific to COVID-19. And everybody is thinking about this, aerosol, the smoke, from smoke it will come out, so it will infect the healthcare workers. Very, very little evidence. And now we have a lot of articles suggesting that compared with open surgery, laparoscopy is safer. The open compared with open. So even in our Indian Association of Surgical Oncology Society, they announced that possible any cancer surgery in COVID time, do laparoscopy, don't go for open. So that is the criteria now. And you have to use the minimize use of energy device, because there is a chance of droplet coming out. The virus can come out from the abdomen, so that once you are dividing the tissue. And then we need a separate concern covering the COVID-19 risk. Suppose you are operating on some intestinal obstruction, the patient may go for some, normally the pneumonia, post-op ventilation is required, or otherwise some lung changes is there. So most of the time, the routine ICU stay, high risk concern we used to get. But in those cases, we have to think that more chance of getting COVID, since already the pulmonary complaints is there. So we need to separate concern for COVID, and then dedicated OR for COVID. Already I mentioned in my slide. And then this is some of the other new point I could see in American College of Surgeons. And then they suggested that intubate in a negative pressure room prior to extubate there too. So what they are advising is, if it is a positive pressure is there, definitely when intubating the patient, the anesthetist is very close up with the patient, so it will come out. The tracheal secretion, the aerosols will come out. It will infect the anesthetist teeth. So that's why they recommend intubate in a negative pressure room. But usually the OT is a positive pressure room. So we need to have a separate intubating room nearby, or you convert one of the OT to negative pressure, and then you can intubate. And then this is already I mentioned. And here they told another new point, consider additional filter for the anesthesia machine. So normally they use the HME filter, one filter inside the boils to filtering this thing. Now we need another filter, additional filter in the boils machine. And this is the UK criteria, that is Royal College of Edinburgh, England, Ireland, and all this almost 7 colleges, they come with these guidelines. And then according to them, if you are taking emergency surgery, do CT thorax, that will give a very good information. And even in a RT-PCR negative patient, and then early signs we can able to pick it up with the CT thorax, the ground glass appearance, a lot of things is there. So nowadays we are following this major surgery. Suppose the patient is going to be in the hospital for 4-5 days after the surgery, then we go for a CT thorax. And then stop positive pressure ventilation, but particularly when intubating time and extubating time. And then here they have another advice that it protects protection for your eyes also is very important, because the mucous membrane can expose, so the virus can if they go to the eyes, then chance of getting infection is more. And then practice donning and doffing frequently, so that before practice don't come, because we'll forget something. So we used to follow the CDC guidelines, Center of Disease and Control guidelines for donning and doffing. So wants to have a practice before going for a OT. And this is our guidelines, and almost all the point they are repeating it. And this is the one CDC I used to follow. So this already in the triage we used to see patient before entering into the hospital. This is our hospital building. You can see with the patient sisters with the coverall, and then they're checking the temperature. You can see the hand wash here. So we have to wash the hand before coming to here, and the physical distancing. And so declaration form, travel history, everything we collect, and then only we can allow the patient to enter into the building. So this is our hospital waiting area. You can see the physical distancing, and even the patient is in the waiting room. And particularly coming to the OT, we have to consider a lot of changes in OT, particularly the air changes. How many cycles, the rotation air changes in the OT, and then filtering system, anything to be improved in the filtering system, and then other thing is called temperature and humidity. So these are all the things, and normally the NABH norms we are following here. This is our hospital, is NABH hospital, and we want some more, one step higher for this COVID time. And this is one of my I took all the detail from GEM OT detail, and even in my background I put the GEM OT. You can able to see, and this picture I have taken today. I operated a case at that time. We took a picture, and you can see the AHU what we have. Our OT is 20 by 20 feet, 20 feet by 20 feet size, and air handling unit. AHU is a air handling unit. That is a 3,000 cubic feet meter. So 3,000 CSF means very dense air is pumping. And then we have a filter, that is one is called pre-filter, is a 10 micron filter, and another one is a fine filter, that is a 5 micron filter. Both the filter will be attached to the AHU unit just outside the OT room, and then air is coming, and then on the OT it is a HEPA filter. It filtered 0.3 micron. So far, all the filters, even our N95 mask, all the filters is filtering only the 0.3 micron size. But the COVID is 0.1 micron to 0.2 microns. So it is a 0.14 microns COVID size. So we don't have any filter right now to filtering the COVID. But if you follow all the protocol, then we will be safe. So what are the other protocols? So the number of air changes should be 40. That means 40 per hour. So in the entire room, 20 by 20 room, OT room, the air should be cycles. A number of cycles. It will come in a laminar flow. It will come in the center of the OT, and then all the corner will be the outlet will be there. So the number of cycles will be 40 minimum. I calculated, our OT is 48 cycles per minute. And then you can see within 48 cycle, the fresh air, entire air will be, fresh air changes will be 9. And then humidity will be 30 to 60. It should be below 60. And then fresh air in the OT is 20% with the total air. So these are all the criteria what we are following it. And you can see the recommendation is 6 fresh air changes per hour, but ours is 9. And then 40 fresh total air changes, ours is 48. So whenever, and this is our AHU, you can see there's such a big one, and then so the cubic feet, it's a 3,000 cubic feet, so that the number of air cycles is more. And this is the pre-filter, it will filter 10 micron filtering, and these are all the other filters 5 micron, and this is within the OT, this is the HEPA filter, so it is 0.3 micron filtering capacity. And we changes we made separate the OT. And then I think OP and IP, I don't want to talk now. And what are the changes we made in OT? So if your anesthesia, laparoscopy is our hospital is almost 95%, I can say it's laparoscopy. So all the surgery we are doing it with general anesthesia. So there's a greater risk with the general anesthesia. And so surgeons, anesthetists are direct exposure from aerosol from trachea and bronchus. So even the small droplet has a lot of viral load is maximum in tracheal and bronchial fluid. So they have a direct exposure. We were to prevent that. And then PPE, that is called hazmat suit. That is otherwise called coverall. So that suit also, there should not be any stitch. When the white color dress, what we are putting, there should not be stitch. If it is a stitch is there, through the stitch hole, the virus can transmit. So it should be laser pressed. So laser pressed, and then there should not be any hole. When joint should not be there, and then the size will be around 22 GSM, 70 GSM minimum. So like a lot of format is there. That is called hazmat suit, and they have to with the visor, and then intubation and extubation in a negative pressure. That means it's without laminar flow, and then we keep the main suction on, and then the negative pressure will be created, and then filter in the circuit, and the circuit filter will be changed every case. We have a two filter. One is inside the anesthesia machine, that is a boils. Another is in the circuit. So we put the circuit filter extra for this nowadays, the COVID era, and then this filter will be changed for every case. And then filter in anesthesia workstation changing every day. Every day we'll change that anesthesia filter. And then we designed a box, intubation box with a suction facility so that the negative pressure will be there. And then you can see this is the humid vent filter. This will be inside the boils. This will be changed every day. And then this is the bacterial viral filter with this filter within the circuit of the patient. And then this filter changed for every patient. And then you can see this is the hood. You can see our anesthetist standing. He is demonstrating how to take using this hood. So you can see this is the OT table, and then patient will be lie down. This hood comes with a very this is the inbuilt glove. There's no need to put a glove. It is already glove is there. Very big hole is there, and then we can put this one your hand, and then you can see this knob for suction. You can connect the suction, and then patient will be lying down. This will be covered, so this part will be negative pressure, and then you can see this glove. These two things is what we designed, and then this is slanting so that his view is view in the when intubating time view is better. You can see is just a patient is lying down, and then he is using this, and then he is intubating. So during the intubation time, you can see he is our head anesthetist, and you can see the coverall, and this is the hazmat suit. There is no stitch anywhere, and then you can see he had a plastic cover up to the knee, and then you can see the visor, and he wear two masks. One is N95, over that is 3-ply mask, and then entire face is protected. So apart from this, he had this hood for a protection. So 2 level of protection he is taking. So this is for anesthetists to have all these protections. And then what about for surgeons? So surgeons, the first level is the mask is the one for all healthcare workers. And then regular 3-ply mask is not good, and they are recommending this respirator. That is a filtering face piece respirator. Commonest one is a N95 filter. And then in N95, 3 type is there: FFP1, FFP2, FFP3. So our surgeons, for surgeons, we need a N95 with FFP3. Or if you have N99 mask, that is well and good, and you can go with the N99 mask. That means N95 is 95% filtering rate, N99 is 99% filtering rate. And then after that, if you want to have some more benefits, and then you can go for this full face piece respirator like this, and then here you connect a P100 filter. 2 filter can be connected here, and this is actually the filtering respirator will be N series, R, and then P. N is only for filtering in the air. R is both aerosols and liquid form, oil form will be filtered, and then P is for almost filtering oil, liquid, gas, everything will be filtered. And then that is also the filtering rate is 100%. That is a P100 filter. So this is a full face respirator. And then if you want to go, this is also both this thing. It required a fit test. It will be fit very tightly. There should not be any air leak. So if you want some more comfortable way, you have to go for this powered air purifying respirator. That is called PAPR. And you can see this is like a hood, and then it has a polycarbonate glass, and then it will be covered. Entire thing will be covered. And then this device will suck the air, and then from the room, and then it will be filtered. There is a P100 filter is there. It will pass the air through the filter, and then through the hose, your face and air will be stored in your face. That is a positive pressure ventilation, so that any from the OT, any fumes or anything will not come enter this hood. So you will be safe. So this is the highest safety device nowadays one can use. So in GEM, we started with the regular 3-ply. This is the March scenario in GEM, March 2020. Regular 3-ply mask changed to N95 mask. And then you can see my cap. Instead of regular cap, I covered this cap. You get both ear is also covered. And then I put a goggle so that my eye is a protection. So like this, I did my surgeries in the March, started with the COVID time. And you can see I'm operating laparoscopic surgery. You can see this is my PPE. I put a 2 masks. One is N95, another is the regular 3-ply, and then goggle. So after that, we feel we want to go some more safety things. Then I started using this. Our companies are making this. After N95, you can put this is a visor, is big visor is there, and then we can put the entire head will be covered. But here there is no aeration inside, and then it will be very very suffocating. Half an hour, more than half an hour, we cannot operate. And that also I used for some surgeries for a hernia and other things. This is the, I think, fundoplication surgery I did. Almost 1 hour to 20 minutes I can able to use this. But half an hour we can do, more than half an hour we cannot operate. And then we changed to this full face piece respirator. And this is the another one of the good respirator. You can see here 2 filter is attaching P100 filter, and then you can see entire face is covered. And then here is totally fit is there. We can tight the elastic on 4 level, 2 overhead, 2 below chin, so that it will be fit to your face. But this is also not very much comfortable, and it will press your nose, and somebody is holding your head, holding your face like, and maximum 1-2 hours maximum you can able to use this device. After that we cannot use. Even I did esophageectomy, gastrectomy with this. I spent 4-5 hours, but even there is a scar marked in my nose because of this. This area will be compressed long time. And one of my colleague got a lymphedema. He got a lymphedema by compression over this mask. So a lot of because he did for he used this mask for a liver transplantation. So a lot of things. You can see this. I'm using this mask for another surgeries. And then after that we changed to this PAPR. The PAPR again 0.3 micron filtering, and we don't want to have 0.3. We want a less than 0.1 micron. So I customized this device, and this is a 3M company hood. And you can see this filtering. I attached to this. My hood is connected to this Honeywell filter. This is a 2 filters there, and it will filter 0.01. You can see filtration 99.99% to 0.01 micron. And this will be connected to the medical air. There is a central supply medical air. We will give it to the boils machine, our anesthesia workstation, and then I'll take out from that. And after this, you can see after wearing a plastic apron and regular apron, I am just placing this hood, and this is very very comfortable and a very lightweight. This is a 3M company hood, and you can see just hood. I placed it. This is the ETO sterilized hood, and then after that, and in the belt I attached the filtering unit here, and filtering unit, and it was connected. The main pipeline is from the centralized device is connected to my filtering unit, and then it was connected to my hood. So now I'm going to get a positive pressure in front of my face over the head, so that nothing will go inside the hood. I'm inside the OT, but the air I'm breathing, it's from the open air. It has a 4 level of filtering, 2 outside, 2 inside the OT. The filtering capacity is 0.01 micron. The COVID will be filtered, and then you can see the air pressure is 2.5 bar, and then the air capacity that is called liter per minute. It is 250 to 300 liter per minute, up to 550 liters we can able to use this hood. So I'm using almost around 250 to 300 liter per minute. So it is like you are in the open terrace, you are feeling the nice breeze, no, without any mask. If you stand in the open terrace, nice breeze, no, that much comfortable will be there. And you can see I'm not putting any mask. And nowadays I'm putting a mask, but those days I didn't put any mask because it is a positive pressure. Nothing will come from OT, and what the air I'm breathing is the outside air. And 2-level filter in the manifold room is coming to the filter, 99% filtering, and then we are giving to the boils for a ventilator, and then same air I'm taking, and then I give it to the manual unit. So again filtering, so it will be very comfortable. And so you just tell me I'm going fast. I want to show some of the evidence, and then some of the changes. And if time is there, I can go fast. Otherwise, maybe I will take another 5 to 7 minutes time. And you can see it is like very comfortable way operating. And 5 hours, 6 hours surgery. You can see how much bulge air is and this glass is also projecting here, also projecting. And you can see this is the live surgery. Today I did a live surgery. That is a E-tape live surgery I made. This photo is taken today. You can see the mic. I'm just talking, and then comfortably I'm doing the surgery. And this is one of the article from Italy and China coming together. What are the lessons learned in minimally invasive surgery during this corona outbreak in China and Italy? So a lot of information I took it from this article only. And then they're telling that pneumoperitoneum, the risk of aerosol exposure is there. Energy devices, again, it will produce plum and surgical smoke. And that surgical smoke, actually the smoke has 95% of water, and then only 5% has a aerosols that may contain COVID-19. That's why the air leak through the trocar, or if we take out the specimen after gallbladder surgery, if we take out the air leak coming out through the port side, it will be there. So this will be this will carry the aerosol, so you have to be take care. The risk of aerolization higher in laparoscopy. This was the initial concept, and nowadays all the article is there, so we don't have any risk. So this is the SAGES recommendation. Even in the SAGES, they're telling that it is unknown whether coronavirus had these properties, whether they escape through this laparoscopy during release during laparoscopy with the carbon dioxide. This is unknown. Even SAGES recommendation is there. So even though as a laparoscopic surgeon, we have to avoid the smoke and gas. What are the systems is there? We have an evacuation system. There is no current data demonstrating that aerosol presents of COVID-19. This is a SAGES recommendation. And they recommend filtration during CO2 release. So what is the simple mechanism? I started using this viral filter. This is 150 rupees, only 150 rupees, Indian rupees. And you can see today also I use this E-tape I did. One of the port is connected. This is just O2 mask tube. I take this, put a ETO tube, and then one of the side channel is connected, and then I filter. This will be, I just drop it here. So whenever I open, the gas will go through the filter. So then it will go to the air, in the OT air. So it will be filtered here. So that is an advantage. And we have a company making a smoking evacuation system. A lot of companies are making it. ConMed. This is a C-Clear device. It is from Cooper Surgical. And then Covidian has rapid back smoke evacuation system. These are all around 5 lakhs to 6 lakhs. If you connect the device to the one of the trocar, it will evacuate the smoke. Simultaneously, the pneumo will be maintained. That is the only advantage with these all the devices. This is Megavac from Ethicon, and Valley Lab Metronics, they have a device. And then Stryker, they have a device, Nemo Clear and PureView. Almost all companies, they have a smoke evacuated device. But I don't have smoke evacuated device in GEM because this is not a very good device, because once the smoke is there, even if you evacuate, it has this to be connected to the central suction. So from central suction, from OT, it is going to the manifold room. From there, it is going out through the rent to the outside to the open air. So this system is there. Instead of that, what I did, I just connect the suction catheter with the slow suction. I release on and off, so it will connect. It will go to the central line. So it is not will be in the OT. So, but the same this device, no, it's what I feel is this is not helping. So instead of that, I'm using a different device. It is called smoke precipitator. So all the companies started marketing smoke evacuator, but if smoke is formed and then we have to evacuate. But this device, I'm using it from Gem Hospital. I'm using it for almost past 4 years. This is called smoke precipitator. It's called Ultravision. The Olympus company is dealer for this. Now they stopped it, and then now we can other companies are there. This device is a scientific way of disappearing the smoke, and we'll see how it is working. This is the company video, and you can see this is a small box like abdomen. You can see the smoke is generated, and this is the electrode from this device. Now they switch on, the electrode is there, and then within 10 seconds, a few seconds, you can see all the gas is being disappeared. So it is not sucking, it is not suctioning. So what happened? This is a negative ion changed to positive ion, and negative ion, it will become a sediment. So this is another video. You can see this lab coli video, and I'm just this ad, and you can see when you are started division of the gallbladder, and within sometimes the smoke will be there inside. Vision will be foggy. So we open the one of the gas, one of the trocar, so all the gas will come out. So if you have this situation is there for all surgeries, so this is the electrode. You have to introduce this electrode near the operated site, 5 centimeters from the operated site. You have to make this electrode, and this electrode should not touch by the camera or the other instrument. It should not be inside the camera view. Now you can see it is here. Camera is coming here. Once the fumes comes, it will be disappear. I have a video. I'll show you. So it will become disappear. So this is a scientific way. So what is happening really? So what is happening? This will remit the positive ion, and then the smoke has a negative ion. It will this positive ion touch the smoke, and then it will become sediment. So it will disappear. How much smoke it comes, immediately it becomes disappear. You can see this is the esophageectomy surgery, thoracoscopy. Patient is in prone. So I'm doing all thoracoscopic trocar. You can see I place this device. You can see inside the thoracoscopic view, the electrode will be like this. So smoke will be evacuated. So this is a gastrectomy surgery. You can see I play most of my place in the nodal dissection will be this area. So I place here. So you can see this is the liver. So the place will be here. So it will be take all the fumes, and then this is the one is very, very useful. So there is no fumes, no need to take out the gas, and then your CO2 level is very, very minimum level used, and then your CO2 also saved, and then there will not be CO2 will not come out the OT, and then aerosol transformation is also reduced. Suppose if you have if you don't have a device, if you have a central suction, use this is a compressor. From the central suction, it is come to the compressor jar, it will go to the OT, and then from the OT again it will go out to the manifold room, and then it will go out to the open air. So if you do the central suctioning, again the air is not within the OT, it will go out. You can use further. So this is for a gas solution. And suppose you are doing a body fluid, some sucking the fluid inside the abdomen. Open surgery, you are doing all the fluid, you are sucking it out. And then if it is to the suction jar, again the handling the suction jar, disposing the fluid, again chance of not transmitting the infection to the sweeper worker, and then again to the staff nurse. So that's way we want to prevent that. We are using this one for a Gem Hospital for a long time. You can see this look a regular suction jar, but there's a 4 jar is connected. Within each suction jar, some bag is there. This bag is full, automatically the fluid go to this jar. Another, so up to 4.5 liter, it's almost 6 liter of fluid can be sucked out. Just for a demonstration, I keep the saline with the methylene blue solution. So what happened? Suppose you are during surgery, you are suctioning all the fluid from the abdomen, all the blood and fluid. You can see I'm just keeping the keeping the tube, so you can see everything is going inside. So once the bottle is full, and automatically it will go to the other bottle. So once you press the this knob, what happens? You can see the silicone powders is spreading over this fluid, and then within 5 to 10 minutes time, within 5 to 10 minutes time, so it will become a solid material. And then after the case, and you can remove the tube, and you can see you can take the outer knob cap with the bag. You can see it is become a solid like ice. So you can dispose like this. So without any drop of fluid exchange, we can dispose. And then it is not cost wise, it is not much. We are spending minimum cost extra for the patient. And then here many times the suction jar, if you take a culture, it has become a positive. So suction jar is one of the source of infection. So even COVID time, we should not clean the suction jar, and with the sodium hypochlorite, even the Sidex, everything, again chance of infection is there. So this type of device we are using in gym, we are safe. You can see I just open the bag, and then you can see the fluid become like a ice, like so that no virus escape from this device. And then how to prevent the air leak, and you can air leak can come through the side channel of trocar, through the washer, and then so that's why whenever you put an incision 5 mm, 10 mm, you can make a smaller incision, and then you can check the washer. There should not be any cut, there should not be any air leak from the washer. So these are all the finer points you can able to make it. And during specimen retrieval, how to control, during port closure, how to control. And I have a small video you can see. You can see before this is all one of the video recorded earlier. You can see my visor is different visor, regular N95 mask with the visor. And what happened, I put a 5 mm trocar, close virus needle 5 mm trocar, and then normally I want to use with the 10 mm camera. You can see after making a 10 mm incision, I'm doing with the port closer. I'm not introducing the trocar. Only some skin incision made, and then I do with the 5 mm view. I take out the port closer needle, and then port closer is made, and then I'm introducing the trocar, so that at the end of the surgery, I suck all the gas, and then immediately I can do for closure of the port. So this is all the way we can able to safely close the port. Otherwise, no, when you closing the port, the gas leak will be there. So like this, some of the different point. And another new thing nowadays, if you have a AC duct, inside the AC duct, the UV light you can able to place it. That is a UVC light. UVAB is not good. UVC is for a COVID sterilizer. And inside the AC duct, you can able to install the UVC with the 254 nanometer, so that air is coming inside, it will be sterilized. And I have a lot of article. It says that there is no scientific evidence to that open surgery is better than laparoscopy. There is no evidence. So laparoscopy, this article shows safe laparoscopy during COVID, face shield, N95 mask, lower the abdomen pressure, and then all the PPI. So this is one of the largest article you can see. They have find out 1098 articles so far, and then only which is best, laparoscopy or laparotomy. They found out 50 article, and then they considered 26 considered in this category. 19 will be retrospective study, and then
Dr. Parthasarathy, can you hear me?
Recommendation.
They
found that laparoscopy is safer nowadays.
Can you hear me?
Some of the things already I explained. This is you can see this is a CO2 tube. This is a suction catheter, suction channel. You can connect, and then you can extend the gas. And when these are all the safety and safety precautions before starting the case, discuss with your team, so that entire team members should know about the surgery, so that senior surgeons to be done by the experienced surgeon. All intubation should be without positive pressure, and then we suggest the intubation box. So these are already I discussed, and with this I will finish.
Yes, sir.
So here that is one of the final point, and then electrocautery, the particle size will be 0.07 micron, but in ultrasonic device you can see up to 6.5 micron. It will come out. And then they found that the open surgery abdominoplasty has a maximum number of exposure. You can see 3,900 particles centimeter square level. They found out 3 articles I can able to see. So we can reduce the flow rate, minimal pressure, and then port closure before induction of the port, extraction trocar, upper abdomen.
Can you hear? Can you hear?
And these are all the safety measures we can take. I think with this I'll finish. And then I like to conclude, evaluate the patient thoroughly before taking for a surgery, and then do COVID RT-PCR for all admitted patients. And then with even the patient attender, nowadays we have started doing it, and communicate with your team. So all the team members should know about the patient's detail, and then separate concern for post-operative complications and separate concern for COVID. Safety measure during intubation and extubation. Already I discussed proper protective equipment, and then safety measure to prevent the air leak, and then smoke precipitator. If it's not available, then you can go for a smoke evacuator. Optimum use of cautery and energy device. So with this, I will finish. Once again, I like to thank the Society of Surgeons of Bangladesh to giving me this opportunity. So now I am ready to take the questions. I think I took.
Thank you very much, sir. Thank you very much.
Sorry,
very much for. Sir, thank you very much for beautiful discussion.
Yeah.
And for long discussion, now we have a short of time, so we go to the panel of experts. First, I go request to the Professor Rafiq Salehin, sir. Sir, you have one question and comments during the OPD management of the OPD patient, and what protocol should be taken by the surgeons during the OPD patient dealing with the OPD patients. And you please comment about the two session shortly, please, sir. Rafiq Salehin.
Thanks to the speakers and thanks to everybody. Just I am starting. This is a very important question, and I think Dr. Jamal and Dr. Partho Sarathi, they have described very elaborately, very nicely. But this portion probably that was untouched, and we are entering into a new era. Probably we have already entered, and we have to change our previous protocols to some extent. Suppose a patient is COVID positive and a person is normal, and they are sitting, keeping 6 meter distance in a room. And if the normal person wears mask and COVID person, he doesn't wear a mask, the chance of infection is 70%. If the COVID person uses mask and normal person without mask, chance of infection is 6%. And if both uses mask, chance of infection is 1.3%. So it is so vital, so important. And we have to take the measure just after receiving the patient in the hospital. Dr. Partho Sarathi, he has just shown a picture that when the patient reaches to the hospital, we have to use a thermal scanner. And after scanning, we will triage our patient. We will categorize our patient. Those who are COVID positive or suspected COVID in a one group, they will go to one side, and the normal patient will go to the another side, and in middle patient, they will be on another side. Because we have very limited resource, we have very limited economic condition, very limited personnel, very limited surgeons. So if we get infected after dealing one patient, that will be very detrimental. And if we loses our doctors and surgeons due to COVID infection, that will be far, far detrimental. So we have to save ourselves. We have to keep ourselves safe side to serve the people. If I get infected and die just after dealing one patient, that is very detrimental. That is very, very foolish. So I have to keep myself safe to serve the people, to serve the patient. So that is very vital. So we'll just triage the patient in 3 categories. And regarding the history taking, again, we have to change. Because first of all, we have to take such history regarding the COVID, whether he is from a COVID, COVID patient, COVID symptom.
This is very, very important.
This is very, very important. And again, examination, we have to very keen and very specific during examining the patient. Again, we have to save ourselves, and we do not want to contaminate the other personnel. And the PP, Dr. Partho Sarathi have shown, we have to use all of the PPs, all of the 2 layers, 3 layers filters. If we deal the COVID suspected or COVID patient, we can use the 3 layers mask. But because it is very difficult to donning and doffing is difficult, but I think very difficult to maintain with the proper PP for a long time. So try this.
We will come with you again, sir.
Yeah.
I think again we will come with you, sir. Now another question to the Professor D. Hasan Chaudhuri, sir. Sir, during dealing with the IPD patient during round, what distance should be measured at that time? And you comment, please, sir. Shortly, please, sir.
Thank you, Nur Hussain. I think Dr. Jamal, Professor Jamal has discussed regarding the bacterial infection. And this part, I think it was not addressed in his speech. So during the word round, before that, answering your question, I'll want to explain a picture in the word is because our wards are overcrowded by the patients and at the same time by our visitors of the patients. So what I have advised, I think that everything should be customized depending on the resources, depending on the situation of the individual hospital. So I have advised my doctors that blood pressure instrument, they have to measure the blood pressure by electronic instruments. Stethoscope, it is better not to use a stethoscope as far as possible. And I have divided the doctors in the ward that the one doctor should see some of the patients in 1 or 2 cube, and 2 doctors should not be exposed to the patient. So to 1 cube or 2 cubes. So less exposure to the of the doctors to the patients. That has to be made sure. But sometimes, if we want to examine the abdomen, if you examine the palpate the abdomen, that cannot be done from a distance. So that has to be done. So in that case, I think I have advised my doctors in my situation that they should wear the PP, they should take the definite personal protection, and then they can examine the patient. But not that one doctor should see 10 or 20 patients, and to that 10 or 20 patients, no other doctor will go there. If they want to consult their seniors, they will consult their seniors over phone, and they will explain the situation to their seniors and take their opinions to avoid exposure of many doctors to one single patient, to avoid the disease transmission. I think something we cannot avoid is because as a surgeon we have to palpate the abdomen, we have to examine the abdomen from close distance. So in that case, you have to take the personal precaution. Thank you.
Yes, sir. So thank you, sir. We will come with you again. And now the question to the Professor Sanullah Sheli from the Professor Sodhu sir, also to the Partha-Sarathy. After ending of the one operation, then how many time to take to interval for the next procedure? Now to the Professor Sanullah Sheli, and your comment, please, sir. Professor Sanullah Sheli.
It is usually Professor Partha-Sarathy have shown it, but one thing left, it is after one operation, it is says as guideline. After one operation, you have to stop operation in that operating room. You have to clean it. Then you can, after cleaning the whole operating room, using the proper different type of, say for example, sanitizing some of the instruments. All instruments could not be cleaned by the same chemical. It needs different types of chemicals. And you have to all those things, then you can come after preparation of the room again. And better not to do the second operation in the same operating room, same day, come next day. Thank you.
Yeah, it has to be fumigated.
Yes,
and
Dr. Partha-Sarathy.
Yeah, it has to be carbolization done to all the equipment, floor to be cleaned and fumigated. So it will take 2 hours time to do all those things. So if we have a COVID OT, separate OT, and even a routine case also, we take a fast if we're doing minimum 1 hour time to clean the OT, then we can take the next case.
Yeah, thank you very much. Now I would like to request. Now I'd like to request Professor Shafkat Hussain Khandekar, sir. Professor Shafkat Hussain Khandekar, please comment about the OPD, IPD, and all the speaker, also the operation theater.
Well, can you hear me?
Yes, sir. Yes, sir.
What I want to say is that everyone here has made a very good presentation. There's no doubt about it. And among all of us who are here, we also are very much aware of whatever is going on, all the requirements. But I feel that there is one major lapse amongst us, which is the cause of many problems, and that is the implementation of all that we know. So I believe that it is very important to implement what we have all said today into our own practices. And that will bring about a very, very big change and reduce the number of problems that we are facing at the moment. I think that is a very key thing which we must take into account. Every one of us knows what's going on, what are the facts and figures. We are all aware of it. So we should take that into account.
So thank you very much, sir. Any comment from Parthasarathi, sir?
Yeah, what sir told is very, very correct. And implementing is a very difficult task. And even surgeons, they are not following the norms many times. And all the healthcare workers, so we need to have a separate COVID team, and they should see everything is going on smooth everywhere the protocol is following or not. So we need a separate team in each level: OP, triage, OP, waiting area, ward, ICU, and OT. So that's why then only it will become good. It will become safe. So what sir pointed out, it is very, very true. And implementation is very difficult. Even hospital ready to spend all, but it should be used properly by the healthcare workers. So we need a separate team to monitor.
Thank you, sir. We have so many our senior teacher here, but also there is a shortage of time. So now I would like to request our special guest, Professor MD Nazmul Islam, Line Director, Medical Education and Health Manpower Development, Director General of Medical Education, and General Secretary of Society of Otolaryngologists and Head Neck Surgeon, Professor Nazmul Islam. Is Nazmul Islam sir here?
It's okay. Assalamu alaikum.
Yes, sir. Yes, sir.
Respected chairperson of this webinar session, Honorable Member of the Parliament, Professor Habib Milad MP, Honorable Vice Chancellor of Sheikh Mujib Medical University, Professor Banakanti Borwa, my respected teachers, my dear colleagues, thank you for inviting me. It was wonderful to hear from Professor ABM Jamal and one faculty from outside the country, Dr. Parthasarathi. I was really amazed with the presentation. And I would like to express my heartfelt gratitude and thanks to the speakers. Really, they had to work hard to prepare all these papers and this sort of webinar programs. I think it's really important for us, for our young surgeons, so that we can cope up with the new COVID situation. And we don't know when we will come out of this situation, but today's webinar, and it's a continuous process, and the Director General of Medical Education, on our half, we will extend our every possible help to the Society of Surgeons of Bangladesh. And again, I would like to express my thanks and gratitude to the organizers. They are so kind to us to invite me in this August gathering. Thank you very much for inviting me. I have learned a lot from this session. Thank you very much. Assalamu alaikum.
Thank you, sir.
Over to you,
We have to need many support from you, as you are in the education, health education area, and the line director of the medical education. That's why many subject equipment needed for all of the, not only for the surgeon, all of the doctors. So we want your help, and we want your extend hand all of our doctors.
Thank you, Shaheen. We were ready to provide necessary equipment for the medical colleges, but it has to be come from your side, from medical colleges, from the Department of Surgery and Allied Disciplines, and on behalf of the principals of the medical colleges. If they send us their requirements, their requisition in time, with specification and all other informations, certainly we can provide with so many things. But yes, unfortunately, they don't seek anything from us. We are ready to cooperate with you, but you need to come forward first. Thank you very much. Over to you.
Thank you, sir. Thank you. Thank you, sir.
Dr. Ali Nafis, sir.
Actually, we just at the end, yes, you just shortly, please.
একটু আমাদের ইউকেতে এনএচএস ট্রাস্টে এই কোভিড সিচুয়েশনটা কিভাবে ম্যানেজ করছে এটা আমরা একটু যদি শুনতাম ফরিদ স্যারের কাছ থেকে, তাহলে হয়তো আমরা কিছু আমাদের ক্ষেত্রে অ্যাপ্লাই করতে পারতাম, যেহেতু তারা ম্যানেজ করে ফেলছে। আমরা কি একটু ফরিদ স্যারের কাছ থেকে শুনতে পারি উনি কি বলছেন, মানে কিভাবে ওনারা ম্যানেজ করছেন?
Oh yes, thank you. Actually, এটা আমরা আরো আগে করতে পারলে আরেকটু আগে আমরা যেহেতু চিফ গেস্টের কাছাকাছি চলে আসছি, আমরা আরেকটা ওয়েবিনার এটা আমরা শুনবো ইনশাল্লাহ আশা করি। এখন যেহেতু আমরা মাগরিবের নামাজও কাছাকাছি, আমরা এখন চিফ গেস্ট একটু পরে বক্তব্য রাখবেন, আমরা পরের একটা সেশন এটা ইনশাল্লাহ যাব। Now we just at the end of the session, before that I'd like to request Professor Konokkanti Burua sir, our guardian, and our Professor Konokkanti Burua, Vice Chancellor BSMMU. I'd like to request Professor Konokkanti Burua sir about any comments, sir. Professor Konokkanti Burua sir. Sir is here.
I think he's
Anybody?
busy with other meeting. I think he's not with us at this moment.
So now we just at the end of the session, our chief guest tell me to request that your program should be complete within 1 hour. So I am really extremely sorry, because it is a demandable and it is important issue how to manage OPD, IPD and operation theater. That's why we have taken some of the time. So now I would request Professor Habibe Millat, Professor Habibe Millat, Chairman, Health Advisory Group, Habibe Millat MP sir, Inter-Parliamentary Union. I would like to request Professor Habibe Millat MP sir.
Very much.
And today's chief guest. Yes sir.
Thank you for inviting me in such a prestigious organization like Bangladesh Surgical Association. As you know, as a surgeon, I'm really delighted to join in this organization after a long time. I left my surgery but about all those days. It was a nice presentation, two nice presentations. Dr. Partha Sharati from India and also Dr. Professor A.D.M. Jamal from Bangladesh. I learned a lot from them. As a medical professional and also a public representative, we need to know about health. Health is priority in the country. You know what we can do during this COVID situation, especially in the inpatient, outpatient theater ICU. I carefully listen to all the presentation and also the panelists, the Professor Dewan Chaudhary. I listened carefully. As you know that as a developing country like Bangladesh, we have made a lot of progress in health sector, even in the specialized sector. In the past, usually millions of people used to leave the country for treatment outside. Still they're going, but number has decreased because of services improved. We need to get the of the people of Bangladesh, and that's why we are all together working for that. As you know that during the COVID came in our country about just over 4 months, almost 5 months ago. We were not prepared at all for that. Our patients and others are now thinking, because the number of patients gone down, people do not want to come to the hospital. What you want to talk is not the as a surgeon, I know. If the only solution, we to avoid surgical intervention, but we need to prepare our nation for that. And we know that the prevention is always better. We can build a healthy nation. Let's and our surgeon, our other specialties. Keep an eye on that. COVID situation Despite social distancing, hand washing, wearing mask, staying at home, we can do all those in the COVID patient or non-COVID patient. That care. Any
Please
vital
mute everyone, please. Please everyone mute.
Not because but we have to take a high rate of death of doctors during COVID. They have sacrificed their lives to save us. We respect them, and we need to keep them prepared and keep them to the end, discharging the patient. We need to be careful. And also, patients should be well prepared that even they have COVID positive or negative, doesn't matter. We have to be taken proper precaution. We are initially a lack of that. Now we have improved. The presentation we saw of Dr. Partho Sarathy, we saw some new technologies that, especially the PPEs. I'm not sure we are using that in this country, but if it works, we don't have a problem bringing all those to our countries, and we can use that. Our safety is important. Also, safety of the patient is also important. So you have to play like that. Another thing is that operation or surgical treatment or hospital treatment is not the only solution. The patient will stay there only for a few days, but they have to live after that. So rehabilitation program, keeping themselves healthy and out of this disease, we need to give them advice. Rehabilitation program, follow-up, we need to do all those things. I know Bangladeshi treatment has well respected anywhere in the world. Bangladeshi doctors are working in many countries in the world, Western world, North America. They're doing their duties. They're getting desperate from the patient. And in Bangladesh, the doctors, the number of hours working in this country, I was working in, work in UK, I work 39 hours every week. But I know Bangladeshi surgeons, Bangladeshi doctors, they work 39 hours in 4 days. I don't know how many hours they work every day. So they are working because our number is shortage in this country. Number of the population is high. Budget is, if it's a government sector, budget is not enough. Even we cannot use that properly, those budget. So there is some problem. There is a managerial problem, not the problem with the doctors. Whatever blame we get, the doctors get the blame, not the manager who is looking after us. In the private and public sector, both true. Why doctor is getting blamed? They are performing their duties. They're looking at the patient, they're treating them, they're operating them, they're giving them the advice. But hospital bed, admission system, in the private sector, the money they are asking is not doctor's responsibility. It is not healthcare's responsibility, but we are getting blamed for that and getting confidence of the people. One thing we need to do is getting back the confidence of the patient or entire population of the country to the doctors. Society of Surgeons and other society are working very hard, but we need to work together. I'm really, really grateful to the society who invited me, especially Professor Tauhidul Alam and Dr. Nur Hussain Bhuya. They invited me. I'm grateful, and I'm always with you as a ex-colleague. I say I left my practice a few years ago, but in heart, in my mind, as a public representative, I'm always a surgeon and as a doctor, as a medical profession, part of medical profession. So please, we need to get confidence. That is the only problem we have in Bangladesh. We have good surgeons, we have good medical practitioners, we have good physiotherapists, we have everything. We are on the international standard. But because of the confidence of the patient, we are not getting that respect from the from the general people. We need to get back. We need to fight for that. I think with these few words, I want to conclude. It was too long, but it was interesting. I learned a lot of things from there. And thank you very much for inviting me. I didn't mention anybody's name because all of them are in this meeting. I respect them. They're my senior teachers. They are my colleagues. They're my junior fellows. I respect them. They're working very, very hard for the country. I salute you, and inshallah, I will join you again whenever you want to join me or whenever you invite me. Thank you very much. Thank you.
Thank you, sir. We know you are a member of parliament. Okay, this is okay. But we think you are always with us as you are a surgeon and you are our colleague and you always with the Society of Surgeons of Bangladesh. We always believe it, and inshallah, you will always help us to establish our duty in the COVID era. So thank you very much for inspiring speech. Now this is the concluding speech from the President, Professor A.H.M. Tawhidul Alam, President, Society of Surgeons of Bangladesh. Professor A.H.M. Tawhidul Alam.
Assalamu alaikum, everybody. Good evening. Today's chief guest, Professor Dr. Habib Millat, MP, and our special guest, Professor MD Nazmul Islam, and my senior teachers, panelists, and participants from home and abroad. I am not addressing everybody because we're short of time. Actually, we are doing, the Society of Surgeons are doing this sorts of webinar repeatedly to aware our surgeons, because you know, by this time we have lost more than 80 doctors, and among them there are a good number of surgeons are there. And so far I believe, though we know that we should follow the PPE and everything, we should wear and we should maintain all the attires of the surgery, but somewhere there is some leakage, somewhere there is some deficiency, we are not maintaining it properly. That's why our doctors are getting infected. What you see, in the COVID hospital, the rate of infection is less than that of the non-COVID hospital. So our doctors, surgeons are getting infected. So this, our intention is to do these sorts of webinar to make alert our doctors, our surgeons, so that we can save ourselves, we can save our family, we can save the patients. And particularly, we invite parliament members, those who are doctors in this meeting, because so that they can see the deficiency of the health system, what we are facing at this moment, because COVID has teach us many things. You see, there in this whole country, there is no operation theater which has got negative pressure. So this is the time we have to improve our operation theater. We have to rearrange our whole system, health system, and that's why we invite the parliament member, that is policy maker, so that this is the time. If you start now, because this COVID will continue for another maybe a few more years. So we have to survive within this COVID, and we have to adapt ourselves within this COVID era. So my request to the chief guest, please ventilate our message to the higher authority, to the parliament, and you know our problem, so that we can prepare ourselves better to combat these sorts of situation if it prevails in futures. And last of all, I thank to the foreign speakers and our national local speakers for their nice deliberation. We have learned many things from their speeches, and definitely we'll try to adapt all these things, and we're trying to, and we're doing it. With these few words, I would like to conclude this session, because we are very close to Maghrib prayer, so I don't like to continue further. And there are lots of my colleagues, senior, junior colleagues are there. Thanking everybody, thanking our Professor Motiur Rahman sir, or Professor Kanakkanti Bodua. I'd like to conclude this session, and in the next session, I would definitely I'll listen something from Dr. Farid from UK. Definitely in the 28th session, 28th we have got another webinar. We'll listen from you. Thank you, everybody.
Thank you, sir. Thank you, everyone. So this is the Maghrib prayer. Thank you, Professor Habib Millat sir, and also the Professor, all senior faculties of our Surgical Society, and Professor Kanakkanti Bodua sir, for enjoying this session. And inshallah, again after it will come with you another topics. Thank you very much. Thank you, panel of experts, and thank you, ACI, for arranging such a webinar. Thank you very much.
Thank you.
Eid webinar live.
ঈদের আগে একটা করব স্যার, আর এখন স্যার
আমরা 28 তারিখে আমাদের ডিপার্টমেন্ট অফ সার্জারি থেকে একটা ওয়েবিনার হবে 28 তারিখে, ইউজ অফ রিজিওনাল অ্যানাস্থেসিয়া ইন ল্যাপারোস্কোপিক সার্জারি। এটার পর 28 তারিখে আমরা ইয়ে দিয়ে দেবো, আমরা এখানে লিংকটা দিয়ে দেবো সবাইকে।
গত ঈদে আমরা মিস করছি
ফেসবুক লাইভটা বন্ধ করে দেন শাহিন ভাই।
হ্যাঁ, এই ফেসবুক লাইভ এটা তো ওদের কাছে
টিভি চ্যানেলকে বলো ওরা বন্ধ করে দেবে।
রাজ টিভি
আছে
রাজ টিভিকে একটা থ্যাঙ্কস, স্পেশাল থ্যাঙ্কস জানাই আমরা।
পার্থ সারথী স্যার, থ্যাংক ইউ স্যার।
Thank you.
Wonderful.
Sorry, what happened? One of my video has audio. Just I muted the speaker, so I don't know whether you talked to me due the time. I took a little more time. I couldn't hear your voice.
No problem. No problem.
Here is muted.
You have covered everything. No problem. You enjoyed your presentation. Thank you.
So we enjoyed and we have to learn something about. So
Yeah, because even it's very sad to hear that 80 doctors expert, and in India it is common people, affected people, and then death rate, mortality rate is only 2.3%, but in affected doctors mortality rate is
In Bangladesh,
11%, almost 5 to 6 times more for doctors. So this is very, very sad, and we cannot see the patients, we cannot sit. That is not our habit. So we need to have this, all the protocols, personal protections. I think we can go ahead safely, if we follow all that. Thank you so much.
Thank you,
sir. Again we'll meet with you, sir, another session.
Okay. Definitely. Thank you.
আচ্ছা নূর হোসেন, আমাদের ডিজি হেলথকে রিসিভ করার জন্য একটা ইয়ে করো। আমরা একটা ঈদের পরে একটা ইউনিয়ন প্লাস আমাদের ডিজি হেলথ করা যাবে স্যার, একটা ফর্মাল রিসিপশন।
আমরা ঈদের আগে গ্রিটিংস, মানে ঈদের আগে কেমন সবাই গরু কিনছে এটা দেখবো, আর হলো স্যার আমরা
আমাদের একটা ঈদের পরে একটা গেট টুগেদার করি আমরা।
স্যার ঈদের আগে একটা গ্র্যান্ড রিসেপশন করবেন না স্যার?
আচ্ছা সময় থাকলে করে ফেলো, অসুবিধা নেই, করে ফেলো।
শাহিন ভাই গ্র্যান্ড রিসেপশন তো হবে না, কারণ এখানে খাওয়া দাওয়া নাই, সুবিধা আছে এমনি
ভার্চুয়াল খাওয়া দাওয়া, ভার্চুয়াল
খাওয়া দাওয়া স্যার। স্যার ঈদের আগেই দেন স্যার,
ঈদের আগে
ঈদের আগে এখন তো স্যার প্রিপারেশনের কিছু নাই।
গত ঈদে আমরা মিস করছিলাম কি
না, গরম গরম দিয়ে দিতে হবে, কি বলেন স্যার? সালাইন
স্যার দিয়ে দাও।
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.